Welcome back to the deep dive. Today is a special edition.
A very special edition.
Usually we're browsing through interesting articles, sort of broadening our horizons, but today we have a very specific mission.
We do.
We are simulating a high-stakes study session. So if you are listening to this, you aren't just a casual learner today. You are an MD candidate.
That's right.
Specifically, we are preparing a student for the Gujarat University Anesthesiology exams.
Exactly. We're adopting a different tone today. I want you to think of me not just as an analyst, but as your senior faculty member.
Okay, I like that.
We are in the war room, and the goal here is to get you ready for a classic, and I mean a classic make-or-break exam question.
The make-or-break, huh?
Oh, absolutely. If you get this right, you demonstrate a mastery of physiology, pharmacology, and crisis management. If you get it wrong, well, let's just say the examiners won't be forgiving.
I love the intensity. Okay, let's unpack this. The topic on the table is intracranial tumors and anesthetic management for posterior fossa surgeries. It sounds heavy, and frankly, looking at this stack of textbooks here, Miller, Yao and Artuzio, Morgan, NEET-SS, it is heavy. But we're going to break it down.
It is dense, I'll give you that.
Yeah.
But it's manageable if you have a structure. And that is the absolute key for you, the exam candidate. You cannot just ramble.
A structure.
So we're going to strictly follow a 17-point structure derived right from these sources to simulate a perfect long answer exam response.
A 17-point roadmap. I like it. Our mission is to convert these dense textbook pages into a streamlined, high-yield audio guide.
That's the plan.
We're going to cover the pathology, the pharmacology, and of course the dreaded complications of the sitting position.
Yes, everyone's favorite.
So let's dive straight into Part A, intracranial tumors. Point number 1 on our roadmap, introduction and exam framing.
Right, so you're in the exam hall, you're writing a long answer. You have to start with a definition. But don't just say, it's cancer.
Too simple?
Way too simple. You need to be precise. An intracranial tumor is not just a neoplasm. You should define it as any mass lesion, whether it's primary or secondary, that's occupying the cranial vault.
Any mass lesion. And looking at Sestos and Miller here, they really emphasize that these tumors act as space-occupying lesions, SLLs, inside a rigid box.
Exactly. That concept of the rigid box is the absolute foundation of neuroanesthesia. Now, why is this such a high-yield topic?
Yeah, why do the examiners love it so much?
Because it tests everything. It tests your fundamental understanding of intracranial pressure, ICP physiology. It tests your knowledge of pharmacology, which drugs affect cerebral blood flow. And crucially for the exam, it tests crisis management.
So on the actual exam paper, what does this question look like? What should a candidate expect to see?
You'll see a few common formats. You might get a short note, maybe asking to describe the pathophysiology of raised ICP. Or the big one, the 20-mark long answer. Describe the anesthetic management of a posterior fossa tumor in the sitting position. That is the question we are effectively answered today.
Got it. Okay, let's move to point 2, classification. This is marked in our notes as very high yield. How do we break this down for the examiners?
You need 2 axes of classification, origin and location.
Okay, origin first.
First, origin. You have primary tumors. These are the ones that arise from the brain tissues themselves. So you're thinking gliomas like astrocytomas and oligodendrogliomas.
Right.
Then you have meningiomas, which arise from the coverings of the brain, pituitary adenomas, and schwannomas, specifically the acoustic neuroma, which is a huge topic for our posterior fossa discussion later.
But here's where it gets really interesting looking at Yao and Artuzio. We tend to think of brain tumors as, starting in the brain.
That's the common assumption.
But the data shows that secondary or metastatic tumors are actually more common than primary ones.
Correct. And if you mention that in a Viva, you score points. It shows you've read beyond the absolute basics. These metastases usually come from the lung, breast, or melanoma.
And the second classification.
Location. This is critical. You have supratentorial, which is above the tentorium cerebelli, and infratentorial below it.
And why is that distinction so vital?
Because the anesthetic approach changes completely. Supratentorial means you're dealing with the cerebral hemispheres. Infratentorial means you're in the posterior fossa. You're dealing with the cerebellum and, most importantly, the brainstem.
And Robbins gives us some pathology detail on grading, right? Should we touch on that?
Briefly, yes. You don't need to be a pathologist, but you should mention the WHO grading system from eye to eye.
Grade I being?
Grade PET is benign, like a pilocytic astrocytoma. Grade 4 is the most aggressive glioblastoma multiform. It's characterized by necrosis and a very high mitotic rate. Just dropping those terms, necrosis, mitotic rate, shows the examiner you've done your reading. Got it. Okay, now for point 3. This is the core of the exam answer. Pathophysiology. We mentioned the rigid box earlier.
This is where you bring in the Monroe-Kelly doctrine. And listen, if I'm the examiner and you don't mention Monroe-Kelly in the first couple of minutes of your answer, I'm getting worried.
So it's non-negotiable.
Absolutely. The skull is a fixed volume. Inside you have 3 things: brain, which makes up about 80%, blood, 10%, and CSF, the other 10%. That's it. There is no room for anything else.
So when a tumor starts to grow, something has to give.
Precisely. We call it compensation. Initially, as the mass grows, CSF gets displaced down into the spinal sac, and some venous blood is extruded from the skull.
And that keeps the pressure normal for a bit.
For a while, yes. But once those compensatory mechanisms are exhausted, you hit what we call the knee of the compliance curve.
The knee of the curve, that's a great visual.
It is, because past that point, even a tiny increase in volume causes an exponential, absolutely catastrophic rise in ICP. That is where the patient herniates and dies if we don't intervene. And tied to this mass effect is edema. Miller makes a very specific distinction here between vasogenic and cytotoxic edema. What's the difference? Why does it matter?
It matters hugely. In tumors, we are mostly dealing with vasogenic edema. This is where the blood-brain barrier is disrupted by the tumor. Proteins leak out into the interstitial space, and they pull water with them.
Okay, so that's vasogenic. What's cytotoxic?
Cytotoxic edema is what you see in ischemia, like a stroke. The cells themselves swell up because their sodium-potassium pumps fail. This distinction is critical because steroids, dexamethasone, work on vasogenic edema. They don't really touch cytotoxic edema.
Ah, that explains why we give dexamethasone for tumors but not for strokes. Okay, what about hydrocephalus?
This connects right back to our posterior fossa topic. If a tumor is sitting in that tight posterior fossa, it can physically press on the fourth ventricle or the aqueduct of Sylvius.
What's a plumbing problem?
It's a plumbing problem. It physically blocks the drainage of CSS. That causes obstructive hydrocephalus, which can rapidly raise the ICP.
So what does all of this, the mass, the edema, the hydrocephalus, what does it mean for blood flow? We have a formula for this, don't we?
We do. The golden formula of neuroanesthesia. Cerebral perfusion pressure, CPP, equals mean arterial pressure, MAP, minus intracranial pressure, ICP.
CPP equals MAP minus ICP.
Or CVP, if it happens to be higher than the ICP, but usually it's the ICP. And the brain has this amazing property called autoregulation.
Right.
It keeps blood flow constant, even if the MAP fluctuates between, say, 50 and 150 millimeters of mercury. But, and here's the trap for the unwary around a tumor, autoregulation is often lost. The vessels are maximally dilated. They're vasoparalyzed.
And that leads to this thing called the Steele phenomenon, doesn't it?
It does. It's a complex topic, but for the exam, here's the simple version. If you let the patient's CO2 rise, the normal vessels and the healthy parts of the brain dilate. They then steal blood flow away from the tumor bed, which can't dilate any further.
So you could worsen ischemia in the area that needs blood the most.
Exactly. The key concept for the exam is that vasodilation in a tight brain is dangerous. You have to control CO2 meticulously.
Okay, that makes sense. Moving to part 4. Clinical features. If a patient walks into the clinic, what are we looking for?
You're looking for the classic triad of raised ICP. You must know this. 1, headache.
But not just any headache.
No, a specific kind.
Mm.
Typically worse in the morning or when bending over, because that's when venous pressure is highest. 2, vomiting, often described as projectile, and characteristically without nausea.
And the third?
3, papilledema, edema, swelling of the optic disc, which causes blurring of vision.
And what if we miss those early signs?
Then you are in deep trouble. You start to see Cushing's triad. This is a very late sign. It signals imminent brainstem herniation and death.
When the triad is?
The triad is hypertension, specifically a rise in systolic pressure with a widening pulse pressure, bradycardia, a reflex response to the hypertension, and irregular respiration as the brainstem respiratory centers are being compressed. If you see this, you are in a crisis.
And since we're focusing on posterior fossa tumors, are there specific focal deficits we should mention?
Yes, absolutely. Infratentorial tumors will cause cerebellar signs like ataxia, a clumsy gait, nystagmus, the jerky eye movements, and cranial nerve palsies. Specifically, look at nerves V's 8 and 8 if it's an acoustic neuroma in the cerebellopontine angle.
That transitions perfectly to point 5. Preoperative evaluation. This is marked as very high yield for the practical exam.
It is. This is where you show you're a safe anesthetist. You start with the GCS, the Glasgow Coma Scale, to establish a baseline level of consciousness.
Okay.
But for posterior fossa surgery, you must specifically assess for bulbar involvement. That means checking cranial nerves IX and X. Ask the patient about difficulty swallowing. Check their gag reflex.
Why is that so important?
Because if it's absent, they're a massive aspiration risk on induction. A massive risk.
And for imaging, what do we need to know about CT versus MRI?
For the exam, know this. CT is great for looking at bone, calcification, and an acute bleed.
Yeah.
But for tumors, MRI is the gold standard. It gives you incredible detail on soft tissue extension and edema.
And what are we looking for on the scan?
You must mention checking for midline shift.
Yeah.
Is it a brain being pushed from one side to the other? Anything greater than about ½ centimeter is very significant.
Okay, so we have our assessment. Now, optimization. We talked about steroids.
Yes, dexamethasone. It's crucial. It works by stabilizing the capillary membrane to reduce that vasogenic edema we talked about. Miller notes it takes about 12 to 36 hours to really kick in. So it's not an acute rescue drug, but it's vital for preoperative stabilization.
What else?
You also load them with anticonvulsants, something like phenytoin or levetiracetam if there's any history of seizures, which is common with supratentorial tumors.
And fluids. This seems to be a common Viva question.
It is. Avoid dextrose. This is a classic exam point. Dextrose causes hyperglycemia. Hyperglycemia during an ischemic event, which can happen during surgery, leads to anaerobic metabolism, lactic acidosis, and much worse neuronal injury.
So what do we use?
Stick to isotonic saline or plasmolite. And the goal is euvolемia. Not too dry, not overloaded, just right.
All right, we've optimized the patient. We're ready. Now we enter Part B anesthesia for posterior fossa surgeries. Point 6. A quick introduction to the posterior fossa itself. Why is this specific region such a nightmare for anesthetists?
In a word, anatomy. The posterior fossa is a small, tight, unforgiving compartment.
And what's in there?
Everything you don't want to mess with. It houses the brainstem, the midbrain, pons, and medulla, which controls your breathing and your heart rate. It houses the cerebellum, which controls balance. And it is bounded by the petrous temporal bone, the occipital bone, and the rigid tentorium above.
So you've got limited access and incredibly critical structures all crammed in.
Exactly. And the surgical access is difficult. That is why the positioning becomes so complicated and so important.
Point 7 then, the anesthetic goals. What are we trying to achieve here? What's the mission?
The primary goal, the one the surgeon cares about most, is a slack brain.
A slack brain.
Yes. They need room to work without having to retract the brain too hard, which can cause injury. We also need strict ICP control to prevent herniation, especially during induction. We need to maintain CPP to perfuse that sensitive brainstem. And uniquely for this surgery, we often need a rapid emergence.
Why is that rapid emergence so critical here compared to other surgeries?
Because we need to assess neurological function immediately. If the surgeon nicks a vessel and there's a hematoma developing in that tight posterior fossa, the patient will deteriorate in minutes. We need them awake enough to obey commands and prove their neurology is intact.
Okay. Point 8, preoperative preparation. We touched on this, but let's reemphasize the airway.
Assessing the airway in these patients is tricky. They may have very limited neck extension because of the mass effect, or just a stiff neck from meningeal irritation. You can't just crank the head back to get a view. Also, looking at Yao and Artuzio, there is a very specific, very important warning about premedication.
Right, the warning about sedation. This seems crucial.
It is life or death crucial. Do not give heavy sedation like opioids or benzodiazepines on the ward to a patient with significantly raised ICP.
And the reason is?
If they hypoventilate, their CO2 goes up. If CO2 goes up, cerebral vessels dilate. If vessels dilate, ICP spikes, and they can herniate and die before they even get to the operating room.
That is a critical safety point.
Yeah.
Now, point 9, intraoperative anesthetic management. This is the core of the practical performance. Let's talk induction.
The goal is one thing: smooth. A smooth induction. No coughing, no straining, no bucking.
Because all of that raises ICP.
Instantly. Straining raises venous pressure, which is transmitted directly to the ICP. We typically use an induction agent like propofol or thiopental.
Wow.
Both are cerebral vasoconstrictors. They reduce the cerebral metabolic rate for oxygen, the CMRO2, and they reduce cerebral blood flow, which is exactly what we want. They help lower ICP.
What about muscle relaxants? Is succinylcholine an option?
It's controversial. Historically, it was thought that the fasciculations from succinylcholine could transiently raise ICP. Miller says it's probably acceptable if you really need it for a difficult airway, perhaps with a defasciculating dose first. But for exam purposes, rocuronium or vecuronium is the safe, non-controversial answer.
And for laryngoscopy itself, that's a huge stimulus.
A massive stimulus. You must blunt the sympathetic response. You do not want the blood pressure spiking. So use adjuncts, IV lidocaine, esmolol, or a decent dose of fentanyl before you put the laryngoscope in.
Okay, patients induced, intubated. Now maintenance. What's the debate here? Tevia versus volatile anesthetics.
The current thinking, and what Miller suggests, is that propofol Teva total intravenous anesthesia is superior for these cases.
Why is that?
It maintains cerebral autoregulation better, and it consistently lowers ICP compared to volatile agents like sevoflurane, which are all vasodilators to some degree. If you must use volatiles, the advice is to keep it under 1 MAC.
And nitrous oxide, N2O.
Big red flag. A huge no. Avoid nitrous oxide. There are two main reasons, and you need to know both. One, it can increase pneumocephalus air in the brain if air gets entrained during surgery.
And the second reason?
The second, and this is the big one for posterior fossa surgery, is that it expands venous air emboli. N2O is much more soluble in blood than nitrogen is, so it diffuses into any air bubble that gets into the circulation and makes it massive. Get into a small, insignificant VAE into a fatal one. Just don't use it.
Okay, that's clear. No N2O. That leads us to point 10, the very high-yield topic. Positioning, specifically the sitting position.
Yes. The classic exam scenario, the sitting position. Why do surgeons love it? Because it gives them excellent, unparalleled access to the midline of the posterior fossa.
And there are other advantages, right?
There are. Blood and CSF drain away from the surgical field by gravity, so the view is clean. And from our perspective, the diaphragm is free, so ventilation is actually easier.
But the risks?
The risks are significant. The number one headline risk is VAE, venous air embolism. Because the head is elevated above the heart, the pressure in the dural venous sinuses is negative. If a vein is opened, it doesn't bleed out, it sucks air in.
And what about the hemodynamics, the blood pressure?
It can be very unstable. Blood pools in the legs, which can cause severe hypotension and a drop in cardiac output. That's why we wrap the legs and try to keep the knees elevated at heart level, but the risk remains high.
What are the main alternatives to this sitting position?
The prone position is common. You have much less VAE risk, but now you have to worry about face and tongue edema from the pressure, and airway access in an emergency is a nightmare. Or there's the lateral or park bench position, which is sort of an intermediate option. But for the exam, you must focus on the sitting position and its complications.
Which brings us perfectly to point 11, special intraoperative complications, VAE. Let's walk through this step by step.
Right. Mechanism. Operative site is above the heart. This creates a negative pressure gradient in those non-collapsible veins, the dural sinuses.
Yeah.
Air gets sucked in.
And where does it go?
It travels through the venous system to the right side of the heart, then into the pulmonary artery. If it's a large amount, it causes an airlock. It obstructs blood flow through the lungs. Cardiac output crashes.
How do we detect it? Miller has a very clear sensitivity hierarchy for this.
You must know this hierarchy for your exam.
Yeah.
The most sensitive monitor is TE transesophageal echocardiography. It can see even tiny micro bubbles of air in the heart.
But that's not always available. What's next?
The practical gold standard is the precordial Doppler. Place it over the right side of the heart, and it gives you that characteristic washing machine or mill wheel sound when air is present. After that, a sudden change in end-tidal CO2.
Why is the end-tidal CO2 changed?
It drops suddenly and dramatically. Because the air is blocking blood flow to the lungs, you get a massive increase in dead space ventilation. No blood is picking up CO2 to be exhaled, so the reading on your capnograph plummets.
And the famous mill wheel murmur that you can hear with the stethoscope.
That is a late pre-terminal sign. If you hear that with your stethoscope over the chest, it's a disaster. The patient is likely in cardiac arrest. You want to catch it way, way before that with your Doppler and ETCO2.
Okay, so management. The alarm goes off, you see the ETCO2 drop, the Doppler is roaring.
Right.
What do you do? What's the protocol?
Step 1. Inform the surgeon immediately. They need to flood the surgical field with saline or apply bone wax to stop any more air from getting in.
Okay, step 2.
Step 2. Discontinue nitrous oxide if you were foolish enough to be using it. Go to 100% oxygen. Step 3. Attempt to aspirate the air from the central line. You should have a multi-orifice CVP catheter placed at the junction of the SVC and the right atrium, specifically for this purpose.
Right.
Step 4. Support the hemodynamics aggressively with fluids and vasopressors. And some people recommend compressing the jugular veins in the neck to increase back pressure and help the surgeon identify the bleeding point.
That is a very clear protocol. What about the other big complication, brainstem manipulation?
This is very common. The surgeon is working right on or near the brainstem, and you'll suddenly see profound bradycardia or hypertension on your monitor. It looks like a bizarre arrhythmia.
And the management for that?
The management is simple. You calmly and clearly say, "Please pause for a moment." The surgeon stops dissecting, and usually the arrhythmia resolves. It's a direct stimulation of the cardiorespiratory centers.
Point 12, monitoring. We've mentioned a few already, but let's list the complete standard package for this kind of surgery.
Okay, you have your standard ASA monitors, of course,
Mm.
ECG, SpO2, ETCO2, temperature. But that's not enough. You need an arterial line for continuous beat-to-beat blood pressure measurement and for drawing blood gases.
And a central line.
A central venous pressure or CVP line is mandatory. It's for two reasons: monitoring fluid status and for aspirating air in the event of a VAE.
And then the specific VAE monitors.
The precordial Doppler. You must know where to place it. Right sternal border, between the 3rd and 6th intercostal space. You confirm its placement by injecting a small amount of agitated saline through a peripheral IV and listening for the change. And, if you have it, TE is the ultimate monitor.
What about neuromonitoring? Yao and Artuzio mentioned this.
Yes, this is becoming more standard. For a surgery like an acoustic neuroma resection, you're trying to preserve the facial nerve. So they use continuous EMG monitoring of the facial muscles. If the surgeon gets close to the nerve and irritates it, the EMG will fire, and you can warn them.
And other modalities.
You can also monitor SSEP, which is somatosensory evoked potentials, and BAER, brainstem auditory evoked responses, to watch for any ischemia or damage to the brainstem pathways during surgery.
Okay, point 13, emergence and postoperative care. You mentioned this idea of the smooth wake-up.
This is an art form. It's one of the most critical phases. You absolutely cannot have the patient bucking, straining, or coughing violently on the endotracheal tube.
Because that raises venous pressure.
Exactly. It raises venous pressure, which can blow out the delicate clots in the tumor bed and cause a catastrophic postoperative hematoma. But you also can't just leave them deeply anesthetized, because you need to check their neurology.
So how do you thread that needle? It sounds tricky.
It is. You use short-acting agents. Avulidocaine can help suppress the cough reflex. Some people will use a remifentanil infusion and then turn it off right at the very end because it wears off almost instantly. The goal is to extubate them either deep or very smoothly and immediately verify that they can move all 4 limbs and obey commands.
And what if there's significant bulbar palsy or you're worried about swelling?
If the gag reflex was gone pre-op or the surgery was very extensive around the lower cranial nerves, do not be a hero. Do not extubate. The safe answer is to keep them intubated and ventilated electively, transfer them to the ICU, and wait for the swelling to go down. Safety first, always.
Point 14. Let's list the major post-op complications.
The big killer is a posterior fossa hematoma. It presents as a sudden deterioration in consciousness, often with apnea. It's a surgical emergency of the highest order. They need to go straight back to the OR to have the wound opened and evacuated.
What else?
Pneumocephalus is another one, especially after a sitting position case. Air trapped inside the cranium, it can cause a severe headache and confusion. And finally, macroglossia, a massively swollen tongue, if they were in the prone position for a long time. You should always perform a cuff leak test before extubating a patient who was prone for hours.
Point 15. Common exam questions and Viva traps.
Right.
Love these. Let's start with trap number 1. The patient gasps intraoperatively. What does that mean?
This is a classic. If the patient is breathing spontaneously, which they shouldn't be, or they trigger the ventilator, that gasp creates a sudden, deep, negative intrathoracic pressure. In the sitting position, that will suck a huge volume of air in.
So it's a massive VAE risk.
A massive VAE risk. Or it could be a sign of brainstem ischemia, stimulating the respiratory center. So the safe answer for your Viva is, I would first suspect a venous air embolism, or possibly brainstem ischemia. I would immediately check my ETCO2 for a sudden drop and check the blood pressure.
Excellent. Trap number 2, why not use ketamine for induction?
Another classic. The classic teaching and the safe exam answer is that ketamine increases cerebral blood flow and ICP through sympathetic stimulation. Modern research is a bit more nuanced, but for the exam, Don't be a hero. Stick to the classic answer. I would avoid ketamine in a patient with a tight brain because of its potential to increase ICP.
And a common student mistake related to the sitting position.
Forgetting about quadriplegia, it's a devastating complication. If the neck is flexed too much, the chin to chest position, to get good surgical access, you can kink the vertebral arteries and cause ischemia to the mid-cervical spinal cord.
And the patient wakes up unable to move.
The patient wakes up a quadriplegic. It's a disaster. So you always mention checking the neck position and ensuring at least 2 fingers breadth between the chin and the sternum.
Point 16. Diagrams and presentation. For a 20-mark answer, you need visuals.
You absolutely have to draw. You cannot just write a wall of text. First, draw the Monro-Kelly pressure volume curve. Show the flat compensation part, the knee, and then the steep rise.
What else?
Draw a simple diagram of the posterior fossa anatomy. Show the cerebellum and brainstem, and draw a tumor blocking the aqueductus sylvius to illustrate how hydrocephalus occurs. And definitely draw the sitting positions setup show the patient, the legs elevated, the precordial Doppler on the chest, and the head fixed in pins. Diagrams get you marks.
Finally, point 17. Summary and exam conclusion. Let's wrap this all up with the take-home bullet points. What are the absolute must-knows?
Okay, here we go.
1.
The skull is a rigid box, governed by the Monro-Kelly doctrine. 2. CPP equals MAP minus ICP. This is your guiding equation. 3. Auto-regulation limits are 50 to 150 millimeters of mercury, but remember, they're often lost around tumors.
Okay.
4. Posterior fossa means 2 big things: VAE risk, especially in the sitting position, and the risk of brainstem arrhythmias from surgical manipulation. 5. The gold standard for VAE detection is T. The practical, everyday standard is the precordial Doppler plus a dropping end-tidal CO2.
And the last 2.
6. Avoid nitrous oxide. Just don't use it. And 7. A smooth induction and a smooth emergence are non-negotiable to prevent a postoperative hematoma.
And if you had to write a model conclusion sentence for the exam paper?
I would write something like, in conclusion, the anesthetic management for posterior fossa surgery requires a meticulous balance of cerebral hemodynamics, constant vigilance for position-related complications like VAE, and a plan for rapid postoperative neurological assessment to ensure patient safety.
Perfect. That was incredibly intense, but we covered the entire 17-point roadmap.
And that structure is your safety net. If you stick to these headings in the exam pathophysiology, pre-op, intra-op complications, you will not get lost, you will cover all the key points, and you will pass.
To the student listening, visualize those diagrams, review that VAE protocol, and walk into that exam hall with confidence. You really do have the framework to crush this question now. Thanks for joining us on this deep dive simulation.
Good luck. Go get that MD.
See you next time.